Hello, everyone, and thanks so much for joining us and giving us 1 hour of your time tonight. We have a fantastic panel, and we have a fantastic case to discuss also. And I will preface all of this by saying that everything that you're going to hear today is real. Nothing has been changed as far as the documentation. And in addition to the documentation you're going to see the outcome of this case. And there'll be some different decision points that we go through, especially during the resuscitation. For this case specifically, we're going to spend a little bit extra time on this with the initial visit because it involves a patient that, no big surprise for the bounce back. The physician who saw the patient at the initial visit knew that this patient was sick. And in just a second, I'm going to share with you the vital signs, which it doesn't take a genius to know that they're very concerning. This patient ended up leaving against medical advice. And to help us get more to the basis of that, we have Marc Calvert joining us. He is a medical malpractice attorney. For over 30 years has practiced defense med mal work. And we have the panel we're going to introduce in just a second here. So you, I'm sure, recognize a bunch of them already. But let me go ahead and just go through just briefly. We have over actually now 175 folks from all around the world joining us tonight. None of our speakers have anything to disclose, and you will all get 1 hour of free CME. So we'll dispense with that. To claim your CME credit, if you point your phone at the QR code, and I'll leave this on here for just a second as well. I'll leave this on at the very end, so you'll have another opportunity to do it. But while I have this up here, I'm just going to go ahead and introduce the panel, which composes of Jason Adler, emergency physician from University of Maryland. We have Brad Goldman, emergency physician with me at Adena Health Systems. We have Amal Mattu, who you might have heard of, also from University of Maryland, and Scott Weingart, who is from Stony Brook and has been a friend of this program and this book for many of our previous Bounce Back book clubs. So really honored and really excited to have everybody here. We have just an incredible amount of expertise on this call here to really try to sort out what happened with this case. So I'll just sort of say hi to everyone. And folks, thanks again for joining us. I really appreciate it. And again, for the participants, thanks for giving us an hour of your time. We hope we are true to it. This is a 33-year-old man. He comes in to the ED with abdominal pain, and he has a history of meth use. And I'm just going to show you his record here. And I've tried to highlight some of the more important parts of it because he certainly has a lot of significant problems. In other words, he has not only this meth use, but he also has a history of Ehler Danlos syndrome, depression, anxiety, sickle cell anemia, bipolar disorder, and if that's not enough, an enlarged heart and post-traumatic stress disorder. So he comes in and he presents about 25 minutes after midnight, or actually half an hour before, and the note is 25 minutes after midnight. Horrible abdominal pain, which is a pressure sensation, started at 6:20 in the evening, and he had 2 episodes of vomiting. He had used crack cocaine that evening. And so he gives this history of the Ehler Danlos syndrome, some vascular issues, some clotting problems. On his physical exam, they say appears older than stated age. He's 33 years old. You can see his vital signs at the top, certainly tachycardic, hypotensive with a pressure of 67/36, and on his abdominal exam, a well-healed surgical scar. So his labs show leukocytosis, anemia, and an elevated lactate level. So Scott, I'm going to bring you in first, Scott Weingart, and I asked it in just sort of a little bit of a funny way. We always tell residents, students, right, the first thing you need to do is recognize sick or not sick. I'm guessing I know the answer to this question of what you're going to say.
Yeah, well, I mean, it doesn't take a critical care fellowship to know. I'm going to go with sick here, Mike.
Right. Okay. So let me just, before we even go further into it, certainly sick, and you would agree that this physician recognized that that's the case.
Yeah, all throughout the chart is a clear recognition that something horrible is going on. So that's
Yeah.
not the issue here.
Yeah. Okay. So I wanted to just have that sort of funny beginning with you because you're going to be a very important part when we talk about a lot of the medical stuff. We're going to take a little bit of a branch here and see what actually happened, which was sort of interesting. And I'm going to share that with the next screen in just a second with what I already said was against medical advice. But Brad, before we go there, interesting to me that the physician ordered an acute abdominal series. So you have done a little bit of a deep dive, and then I'll tell you my bias on this test in a few minutes, which I'm guessing folks already know. But what do you think about that acute abdominal series order, Brad?
So first, I just wanted to make sure that we differentiated the KUB from the acute abdominal series. Again, I was puzzled why people are still ordering this. There's nothing really in the literature that I've been able to find to support this, to differentiate certainly somebody as sick as this. I mean, for certain specific indications it might be, but not here.
So I always think like really the only indication for acute abdominal series in my practice is like a swallowed metallic foreign body. Almost a couple of years ago, you and I gave a lecture in Los Angeles, and we talked about, understanding limitations of history when, the testing trumps the history, and then understanding limitations of testing when the history trumps the tests. So just to sort of bring this little minimal point home here with the acute abdominal series, what is your thoughts, and do you ever order this in your practice?
Yeah, well, I guess just to throw a little bit of debate out there, I'll take an opposing stance that, first of all, I don't think that we should ever be dogmatic about anything in medicine. If you try to be dogmatic and say, I never do this, or you should never do this or that, then I think sooner or later you're going to be wrong. In this particular case, I think getting an abdominal series, as long as it involves an upright chest x-ray also, would be a reasonable thing to do. He comes in with what seems like, on the chart at least, peritonitis. He's diffusely tender. He's got moderate guarding. He's got a firm abdomen. So if this is peritonitis from a perf, your upright chest x-ray is going to give you an answer right off the bat. And it's certainly going to be an answer much faster, an hour or two faster than getting a CAT scan. And if you see free air, then you're pretty much done. You know where you're going. You're calling surgery, you're making them NPO, you're starting fluids, you're starting antibiotics, and you're prepping them for the OR. So I think there's some benefit there about, in a really, really tender belly, about getting the abdominal series. And also, if there's distension, which I didn't see that, but if somebody has distension and a lot of vomiting, there's a possibility of a bowel obstruction, and an x-ray could give you that diagnosis early, once again, which is going to prompt you to start getting this patient ready for surgery and calling surgery a lot sooner than if you have to wait for a CAT scan. So there could be an opposing view there as well.
Okay, well, look, always the voice of reason. And the fact is that, yeah, maybe if CAT scan would take a long time, or you're in the ED and CAT scan is sort of open, well, maybe that would sort of like help you, as long as you don't really just rely only on that CT scan, because again, this guy obviously has something bad wrong going on and has a negative acute abdominal series. So certainly interesting to think about, and maybe actually something that for me to think about if there ever is that timeliness type of consideration. But I will say that also, since we are talking controversy, on the other hand, I don't think I've actually ordered that acute abdominal series in the last 20 years. So, interesting, just sort of depends on the specific practice. So Jason, we're going to ask you a longer question in just a second. So Jason Adler, so far, you being a national documentation expert, do you feel like so far this documentation is pretty good and gives a nice picture of what's going on?
I do, Mike, and the history is really well written. It articulates a young, young male with a sudden onset of horrible abdominal pain. It was abrupt in onset, timestamped 6:20 p.m. And there's a reference to recent use of crack cocaine. He's never had pain like this in the past. There's a mention of the past medical history and surgical history of EDS, and then subsequently, or the latter, of a splenectomy. There's some associated symptoms and some noise around there, any respiratory complaints. Really well written HPI overall. As you shift downwards towards the exam, again, the emphasis is on the abdominal exam. You've got a surgical scar, as you mentioned, but most importantly is the word guarding. High alert, right? High alert. It jumps off the page. And then, because we know this case does involve a bounce back and a potential AMA, we focus on the neuro exam and we see awake, alert, and cooperative. Awake, alert, and cooperative. And that's an interesting statement to use, and it's easy to say. But imagine the range of mental status patients that we see that fall within that statement: awake, alert, and cooperative. There's a reference to some movement and sensory. And we all know that a neuro exam without at least reference to the gait can be problematic. Overall, very well written first chart.
Yeah, and just a quick note on the neuro exam. I oftentimes see residents document that across the room neuro exam, the eyes are people equally around and they're moving all extremities. And I'm sort of thinking to myself, it's like, that's not really a neuro exam when you actually get up there and check the cranial nerves and cerebellar function. However, I get it that the patient is sitting there and, alert and cooperative, it is a curious way to put it, but that's going to be really important when we get to our next point. And so what I want to do, because this is going to be one of the main things we talk about tonight, which is this patient that left against medical advice. Obviously, as Scott told us earlier, the doctor knew this patient was sick. So Brad Goldman, if you wouldn't mind just sort of reading through the important parts of this AMA note, and then I'd like your thoughts on it. And then what I want to do is bring Marc Calvert in, and then actually prior to this program, Scott actually had some questions for Marc a little bit earlier offline that we'll bring in also. So Brad, you're up.
Very good. So starting with the progress note, it says the patient's significant other was irritated, and I wanted the patient to sign out against medical advice because she needed to get to work. I did go back and reevaluate the patient. He had drank 1 dose of contrast, was able to drink another cup, and at that point he said he would be willing to stay. When the CT tech arrived to transport him to the scanner, his significant other refused to let him go to the CT scan and said she needed to get to work and wanted him discharged. Repeat blood pressure at that time was 103/54, heart rate 136, respirations 18, and oxygen saturation 99% on room air. I did go back and speak with the patient and family members again. At this point, he was sleeping comfortably. The family member was markedly irritated and agitated and was refusing to wait any longer, stating that we should discharge him at this time. We did discuss the incomplete workup and marked lab abnormalities, and the patient did sign the AMA form and leave in spite of having continued abdominal pain. I've had extensive discussion with the patient and family members. We attempted to complete the workup, but ultimately they decided to leave. And the diagnosis is on the chart: abdominal pain of uncertain etiology, cocaine abuse, leukocytosis, anemia, elevated lactic acid, renal insufficiency, and hyperglycemia.
So certainly, obviously, based on that diagnosis, the physician was aware of those lab abnormalities, the vital sign abnormalities. So let me just ask you, Brad, quickly, your thought on this progress note. I'm going to bring Jason in, and then we're going to pivot pretty quickly to Marc Calvert, our defense med malpractice attorney.
One of the things that I noticed was, if you said right there, he was sleeping comfortably, but then he was leaving in spite of having continued abdominal pain, which is a little contradictory.
Okay. All right.
And the other thing that concerns me, I've had, quote, extensive discussion with the patient and family members, end quote. It's kind of unclear what exactly that entailed.
Okay. Jason Adler, what do you think? You've reviewed hundreds or thousands of charts and have lectured on this very topic. What do you think as far as there's a lot of words here, but do they say the most important things?
Yeah, without reading everything over again, we see at least that there's a second touch and there's a repeat assessment. You've got vital signs, and there's another conversation, and then all of a sudden there's a pivot we don't know when in the course that occurred, but there was a pivot talking about an incomplete workup, lab abnormalities, and the patient signed the AMA forms in spite of having continued abdominal pain. So on that topic, and then there's some conversation about the significant other who was involved. So the two elements that jump off in my eyes are, one, that we have a heavy emphasis on the AMA forms were signed despite the patient having continued pain. And then as a follow-up, there is conversation around the significant other and that piece there. We'll leave the second part alone for a moment, but for the first, I would offer that regarding, again, leaving a patient leaving against medical advice, the forms matter. No one will debate that, and I'll have Marc, you can comment much deeper. But I think the process matters more than the form matters. And what I mean by that is there's a process that goes into signing a patient out, and that involves determining medical capacity. It's about making sure that the patient understands the risks and benefits of what the treatment decisions are and the alternatives of treatment, the risks of leaving at that time or having a different potential what's available to have the next step, having them verify that. And you could just do that as simply as them repeating back to you what they're saying. What was the significant other's role? I may or may not be a power of attorney, but she was there, and what was her input? So the form is a piece of the conversation, but the process is critically important.
So let me do this before I said we are going to get to Marc, but before we do that, Amal, I want to just bring you back in here because say, for example, you're working on shift and we have AMA patients leave because, they refuse I don't know, LP for meningitis, or it's probably not going to be meningitis or something that, probably they're still going to be okay. This patient we know is not going to be okay if they leave. Your resident brings this progress note to you. I'm not saying it's terrible, but are there some other things that you would want in this note that are not contained here?
Well, I guess in general, the sicker the patient, the harder you want to really try to keep that patient there. And this is a really sick patient. And so you're going to want to spend a lot more time in that room trying to convince him, trying to, if necessary, scare him into why he needs to stay. And also the significant other, it's kind of a strange relationship going on here. And that's not really clear on the paper. What's up with this relationship where she's demanding that he leave? Why can't he just stay there through the morning? And give him an Uber ride home if everything turns out okay. Why is she demanding he leave? And so I would like a little bit more delving into what's going on there, and also how lucid is he? How much does he really understand? And so you might want to document that the patient really is lucid. He understands. He can restate the risks back to you, and also if there's some kind of reason that she's insisting that he go, just the fact that she has to go to work. Well, he doesn't need to go to work with her, so he can stay.
Right.
And if nothing else, I would, if he's still insisting, I would get him up and see how he looks and feels walking. Sometimes people get up and walk and get real lightheaded, and they realize, you know what, I better not stay. So I would like to see a little bit more documentation, more of the same, and just maybe even documentation of how long they were in the room trying to convince his family, and also witnesses as well.
So, Scott, I know you have some other questions for Marc, but before you even get to those other questions, we might as well just get all the emergency physicians to sort of weigh in, and then Marc will tell us a little bit differently, maybe if lawyers look at that differently. So, Scott, what are your thoughts on this medical decision-making note?
Yeah, I thought it was pretty good. There's some things I would always have that this one didn't. One would be on a patient with this degree of serious illness, I would want written on this note that I told the patient they could die. And I don't see that here. That just really makes abundantly clear that I told them worst case scenario and that they understood. And I'd actually have them stating they verbalized that understanding. And then the next thing is, and this is akin to what we will talk about with Marc, is why does the patient want to leave? Because that gives me some opportunity to see if I could actually abrogate some of those issues for them, and I'd like to see that and show it be addressed. And, the patients, if they then, had an issue and the wife said, well, it's because he needed his dog walked and we could have fixed that, then it is a problem I could have staved off. So those are the two things I would want to add, is the worst case scenario and all the other bad sequelae, but really that worst case scenario needs to be there. And then a rationale that the patient has. I mean, if they tell me because the hospitals take over our brain and they're filled with space aliens, that's an entirely separate branch point. And since I don't know why he's actually wanting to leave, it's not really, I'm not able to address that in the chart.
Well, I think it's important to spend some time with this note because we all have patients, of course, in our careers that leave against medical advice. And there's a lot of sort of lore out there, and there's how we do it. And we think that how we do it is the way it should be done. So, Marc, now you've heard everybody weigh in. And just for example, if there was a bad outcome, saying that there is, and if a lawsuit ensued, where do you stand as the defense attorney defending this chart? Maybe it's fantastic, or maybe you're going to tell us that you also would wish something would have been done a little bit differently.
I think everybody got it right. What I would say is that the note could be better, but I'm convinced by the tenor of the note and some of the important wording that the patient did have the decision-making capacity. So, as you work down the decision tree, the first rule is that an adult has the right to control their body. And so they have a right to consent and they have a right to walk away. And you really can't do anything about that unless there is some evidence of a lack of capacity and competence. I don't see anything in the record that indicates that. Now, I would like to see more in there. I think all of them have identified these areas because the burden of proof seems to shift onto the doctor's shoulders if there's a bad outcome. So technically it's on the plaintiffs or the family's shoulders that are trying to prove, but really the jury wants to hear, why would you have let this man go when it turns out he didn't have capacity, or when something bad happened and there's really no indication that you tried to underscore the seriousness of it. So I would like to see more in the note, and everybody's identified that. More bullet points of what could happen, a little bit of an ominous tone, the amount of time that was spent. I also think it would be helpful to have a witness back that up, mentioning the witness in the note, and just a little bit more beef in the record itself.
So let me ask you this question, just sort of rubber meets the road with this. So say, for example, this patient was intoxicated with cocaine, or for example, they had septic shock and they had some sort of encephalopathy and they weren't really able to adequately think clearly. Would that argument hold water later to say something like the patient didn't have capacity to make the decision to leave, and nowhere in this progress note, this AMA note, was it reflected that the patient did, in an objective way, demonstrate capacity, except for the fact that they were able to walk, but they didn't, tell us the day, the month, the year. I mean, a lot of people that can walk, but have no idea, it's like, 1963 and Kennedy's still president, right?
Right. Well, again, you want to be able to put your best foot forward in this note and be able to show later on that you dotted the I's and crossed the T's. I think putting in there some talking points like alert and oriented, maybe even mentioning that you talked about other subjects. Generally capacity is a medical question, and competence is a legal question. And so there may be competence on some things, and there may be capacity on some things. With respect to this specific question, does he have capacity? If he's intoxicated or there's evidence of intoxication and it is against his best interest to be discharged, then I think you have some bona fide arguments to overrule that decision, because in your reasonable judgment, he is incapacitated to make this decision. Now, it would be curious to see if the significant other has power of attorney and has a voice other than just kind of on the sidelines, luring him away. It's an unusual fact, and I feel that he's giving in to his detriment, and that's certainly contributory negligence, but it's not a sign of incapacity.
And then the final question to you is really back to Scott's point. I do this sort of what Scott was saying too, is I will say, what could happen if the patient leaves? And invariably death is one of those things that's in there. So is that something that would be protective legally later if we really hone down on the specific thing that could happen to that patient if he leaves, and we put that in our note?
My advice to doctors when you're in a serious situation, and I think Dr. Mattu did describe this perfectly. It is a serious situation. It requires a serious amount of time. Is write this note as if it's going to be in front of a jury, because it may well be. So you want to be able to capture in a concise way the seriousness of it. And I think you should put in there the most serious ramifications that could happen, that these things cannot be ruled out. And I instructed him with some degree of fervor that he was risking his health significantly if he were to leave. I think that type of language shows the jury you did everything you could do, and he just would not let you do your job.
So one question from the chat. This is from Sarah. She says, how would this be different, or how should the documentation be different if the patient eloped instead of saying that he's leaving AMA and waiting for those AMA papers?
Well, obviously it depends on the process. At what point did he elope? But I think that early on, the doctor probably should spell out what the significance of the situation is from a medical perspective. We're going to do some tests on you, but I want to let you know that your lab values are markedly abnormal. We're concerned. We've got to run some more tests that are going to be more revealing, but I just want to brace you a little bit that this is potentially serious and you may be admitted. And if you do that early and then they bolt, you make sure and put that in the note. And I think you've done what you can do. Did you act reasonably? That's the umbrella over all of this. And that sounds like pretty darn reasonable care to me. If he runs out 30 minutes in, you've done what you can do.
Yeah, it always seems to me a little bit less, at least legally, risky when the patient elopes. And like, we're really going to send the police or something after the patient. I mean, typically you wouldn't necessarily do that unless the patient didn't really have that capacity. But, with this patient, obviously we have the time. He's waiting for the papers. He's signing the papers. So I want to so we keep ourselves moving, because I want to get to the critical care aspects of this very quickly. So just to summarize, it sounds like what everyone is saying, the note is good. there are a couple of things that could have been done that would have made it just a little bit better. And this is a little bit of our differential, which is a little bit different in a patient who has drug use when they present with abdominal pain. So this guy obviously had a surgical scar. He could potentially have small bowel obstruction. He had sickle cell disease, could have a sickle cell crisis. Something like catastrophically devastating at AAA would be unusual at this age group, but a thoracic aortic dissection certainly could be. Mesenteric ischemia, maybe that cocaine made him hypercoagulable or vasoconstricted, right? And then with drug use, we don't know if it's injection or not, but endocarditis, bacterium and sepsis will all be possibilities. I'm sure there's more too. This is, we talked about briefly Justice Cardoza, or maybe we talked about that offline just prior, but he was a Supreme Court justice who wrote that opinion that says that a physician who does something against the patient's wishes is guilty of assault, potentially guilty of assault. And this was, and you could look at this all up on, the prime source of all of our information, Wikipedia, right? It was Mary Schloendorf who consented to have her abdominal area examined under ether, interestingly, obviously a long time ago. And the physician found a fibroid, did surgery, and then no big surprise, she became septic, had multiple digits and limbs amputated, and sued the physician for assault because she didn't consent to have the operation to be done. And that's where this whole concept of battery and about the patient can make their own decision. This is where all came from, is this Supreme Court justice that you see on the screen here. One other very quick final thing here is if anyone thinks they can like scare a patient into staying because they say their insurance won't come, this is a study in the Journal of General Internal Medicine, and they looked at over 500 patients who left AMA and found there are no cases of payment refusal in those patients. So before we go to our next part, I'm just going to go around the room very, very quickly here. We can go in alphabetical order. And I think I also know the answer to this question too. This patient wants to leave. We know he's super sick. Who keeps this patient against his will? Who calls security and keeps his patient? Jason Adler? Yes, no.
No.
Brad Goldman? Yes, no.
No.
Amal?
No, I don't think we can.
Scott?
Nope.
And Marc Calvert, I assume that you would agree as the defense attorney that that would be some overreach at this point.
Absolutely. I think if you do that, you're going to get sued for false imprisonment, battery, and possibly have a board action filed. So it's a tough situation, but ultimately they get to be negligent if they want to, and it's their body.
Wow. With all of those things, I sort of feel like I almost just got in trouble for asking the question. So, all right. So that's pretty clear. There could have been things done to improve things a little bit more. So I'm going to tell you what happened, and then we're going to move into some of the bounce back critical care aspects of things. So the patient left, and 7 hours later, they returned. And actually, they returned to the ED that I was working. I was not there at the time, but they came from a different ED to the ED that I was working in. 9 o'clock in the morning, chief complaint of abdominal pain. The nurse received the patient from EMS. He was moaning. And as we all sort of know, a patient who needs to urinate or defecate, that could be a potentially bad sign. And just after they arrived, I mean, within minutes, the patient began to seize. The physician is called into the room, and this documentation was obviously done later at 9:56 a.m. And they had put there, you can see that they had seized right after being put from the stretcher onto, or from the ambulance into the stretcher, and the also history of the cocaine use. So Scott, let's bring you back in here, and now we'll have you take your legal hat off and your AMA hat and get us into that critical care aspect of things. So this is a patient who has a witnessed arrest. We know some of the history of it. Ehler Danlos, sickle cell. He's a cocaine user. Just sort of walk us through how you're approaching this when you get called into the room, this patient is seizing, and why is this patient seizing?
Yeah, well, on this particular patient, the question is, does the patient have a pulse? And we don't know the exact timing between the seizure and the cardiac arrest that shortly ensues. My guess is it's almost instantaneous. And it's not commonly spoken about, but it's not uncommon for cardiac arrest to be preceded by seizure-like activity. And I don't know if that's actually epileptic in foci or it's more of the convulsive syncope, but either way, it's been well reported, especially in shockable rhythms. So my guess is that's probably the case. And whether that's due to brain malperfusion, hypoxemia, or et cetera, that is not uncommon at all. And I think that's what happened here. But you'd still treat the differential of like seizures very quickly, or if you can get the diagnostics even better, so you check for hypoglycemia. You'd make sure the patient doesn't have anything focal neurologically that you could perceive, like only one side of the body's shaking or what have you. But this is cardiac arrest. It trumps the seizure by far, and I'd probably just be dealing with this as a generalized arrest until further notice.
So a follow-up question, knowing some of this history, which you probably didn't know as the physician walking in the room, whichever physician was called and just sort of walked into this seizing patient who was probably arresting at the same time, right? But knowing now what you know with some of these other comorbidities, anything differently you're going to do in the initial part of the resuscitation based on some of the other things specific to this patient as opposed to a 33-year-old marathon runner?
Yeah, I mean, he's a sicker patient, obviously. He has a genetic vascular disease with the Ehler Danlos. But I don't think we're going to be able to do much different because we didn't really, even if we had that first visit, came to us and bounced back to us, we still don't know what he had. And while there are some horrible things on the differential, I don't think too many of them are going to affect our initial management of cardiac arrest, with the exception of what I would have loved to see on the first visit and certainly would like to see on the second visit is a general screening ultrasound exam done by the ED providers would have given a bunch of answers in the first presentation and we'll give a bunch now. We will eventually see that, so I won't reveal what that shows, but that would be what I'd be doing early on my arrest in a 33-year-old, because there has to be something strange going on here than the typical cause. I mean, it might just be the typical cause. It might just be early onset, coronary artery disease. We see it, 25-year-olds, 22-year-olds, but it's not as common. So I would want the ultrasound there even quicker to see if something weird is going on.
Okay, so Amal, same question to you. You walk in, this patient just goes straight into arrest. What are you doing, checking the blood sugar, like a lot of things that Scott said, anything additional or maybe different, or just maybe even taking us to the next part of that resuscitation as far as some other things you're going to look at here?
Sure. This is about when I sign out. I'm just kidding. No, I agree with everything Scott said. I think if you know that he's come in for abdominal pain prior to this arrest, then I think we'd be going to a fast exam really, really quickly. And so I'm curious to find out what that showed. Take a look at the heart, the lungs, take a look at the belly. That doesn't take too long. And with the chief complaint listed on his second visit as abdominal pain plus cardiac arrest to me means you're going to probably want to get surgery involved early. You want to consider the possibility that he's bleeding out from somewhere in the belly, especially if you know that first visit. But even if you don't, abdominal pain, now he's in cardiac arrest, you might consider going ahead and starting massive transfusion protocol, especially if they did have vital signs on arrival. I don't remember if he had any specific vital signs on arrival, but if his blood pressure was low and or tachycardia, you're going to probably start transfusing him. And then the other thing that I'd be curious about is what was his initial rhythm at cardiac arrest? When he was identified as being in cardiac arrest, was he VFib? Was he having a Brady asystolic arrest? Was he having a slow, wide rhythm, which might make you think about an overdose? He's got a history of substance abuse and depression. Could it be an overdose where you're going to move towards calcium and bicarb early? Was there, does he have dialysis grafts on, anything like that? So getting a look at that initial rhythm or asking the nurse who was in the room what the initial rhythm was could point you in a direction that could be helpful. It's not a guarantee, but it could definitely be helpful to know what that initial rhythm was. And then the last thing I'd want to know is, how was he breathing when he first arrived? Was he hypoxic and tachypnic when he arrived? And that might suggest maybe there is a pulmonary cause, maybe a PE, and this is a respiratory arrest, in which case we're managing the airway really quickly. Or if his pulse ox and respiratory rate were okay, he was talking okay, then we're not in an absolute rush to manage the airway early, and we're heading more in a cardiac direction. So there's a few questions that could be helpful, even if you don't have the chart from 8 hours ago.
It's so interesting to me how if you just think about going down an ACLS pathway with a patient like this, I mean, all the things we've already talked about, even such as potentially blood transfusions or a patient with the history of the Ehler Danlos, and then you're even thinking about access. And getting to that question of access, Jason, I wanted to bring you in with a question. It sounds like the paramedics sort of did like a bit of a scoop and run. And you'll see in a second when I show what the actual physician did at the beginning here. They the nurse hooked the patient up to the monitor. It sort of makes it seem to me like the patient didn't have a monitor initially. Now, maybe that's because the paramedics had run on this guy before and they thought he was using drugs and they just sort of put him on the cart and brought him in. But, this patient, assuming that he does not have an IV at the time, Jason, how long do you wait for the nurses to try to get a peripheral IV in? Because honestly, without that, I mean, there's not tons we're doing besides chest compressions here or defibrillation based on what the rhythm is.
Yeah, you're kind of trapped. So in a crashing patient, an arresting patient, where time is of the issue, a reasonable approach, reasonable, would be 2 attempts at a peripheral IV within the first 60 seconds until you transition over to IO. There's good data that show that IOs are safer, faster, with fewer complications than a central line. And it's faster, 2 attempts, 1 minute to just get some access to start treatment.
So, Brad, similar sort of quick take type of question here. I'm putting you in the footsteps of a rural emergency physician, single coverage, and you have time for this patient here, but you are the only doctor there. What are you doing first, with the choice being intubating the patient or running the code and gathering additional data, assuming that you're bagging the patient and you feel like he's being adequately ventilated?
Well, Mike, I've certainly worked in small ERs. In fact, the smallest one was 3 beds and then expanded to 5 beds. But it was myself, a nurse or two, and then we pulled a nurse from the floor. So I think intubation at that time, I don't think that requires my immediate attention. I think they need me to do my doctor thing. And as far as as long as you could bag the patient adequately, I think doing high quality CPR, high flow oxygenation, getting IV access and then IO quickly, getting the meds on board, seeing what the rhythm shows, and if there's an ultrasound available, doing POCUS as soon as you can would be helpful. And all the other things the other panelists have said, I completely agree with. It's just
Okay.
you're doing them yourself.
What's that?
It's just there's nobody else there. You're just doing it all yourself, pretty much you and the nurse and the RT.
Right. And I think really now, and Scott, I'd be interested in your thoughts on this, is the data is pretty much there that if you're adequately ventilating the patient, I mean, there's always the risk of aspiration, right? But compared to the risk of nothing else really being done while you're concentrating on that intubation, and again, that might only take 60 seconds, right? By the time you walk to the head of bed and just do it if you have respiratory there. But do you agree, Scott, that we can, if we're single coverage, concentrate on this other stuff as long as we're able to adequately bag the patient?
Yeah, well, and this is going to play into my biases, but we're never single coverage because in the smallest ED, there's always a nurse there. And I think the nurses should be running the code in these circumstances from the perspective of all the routine ACLS stuff. And that gives you time to now do the other things like airway management and ultrasound and talking to history providers. But that being said, I don't think intubation needs to happen early on. I'm not a big fan of this bagging the patient thing. The data says it's as good. And I'm sure it is in the studied environment. It never plays out so well in real life. And when you have the opportunity to place something like an LMA, which takes, 10 seconds, and then let respiratory therapy bag through that and then intubate when you get a chance or not at all, I think that's the way to go. But you'd be supported if you just let them bag with a BVM throughout the code by the literature.
Okay. All right. So let's, in the interest of time, we'll keep things moving here. And here is what happened. You guys were asking about the rhythm. So this is the code sheet. At 10 after 9, the patient becomes apneic and pulseless. That's, honestly, within a couple of minutes of arrival. It was PEA on the monitor, initiated CPR, did epinephrine, respiratory. Patient is intubated. So 6 minutes after they got connected to the monitor. Let's see here. CPR continues, and they're giving epi and bicarb. So what I want to do, Scott, is bring you back here because, it just feels like to me what we're doing here is not going to work. Like it's almost not necessarily for a Hail Mary kind of pass, but you mentioned the ultrasound before. What are the things that we're specifically looking for that are actionable that we could do something about that we would see on ultrasound?
Yeah, well, I mean, the rush exam just takes you through them, right? So on the heart, you're looking for pericardial tamponade as a reversible cause of arrest. You could actually find large amounts of free fluid in the belly. Now, that's likely blood, as Amal intimated, but it doesn't have to be. It could just be ascites, especially if this patient did have something like mesenteric ischemia and just been third spacing tons of fluid. So I would actually stick a needle into that fluid pocket and just immediately get an answer as to whether this is ascites or blood. And if it's blood, that's also a potentially amenable situation. Just as Amal said, transfusing that patient could turn them around, especially if they actually had a heartbeat along with the absence of a pulse. And that's a really salvageable patient. They just need additional volume to bring up their ability to actually perfuse the rest of their body. So that is a reversible cause. Pneumothorax, though, it seems strange. There's nothing to predispose to that, but you could find that in occasional arrests. But those are going to be the big ones you're going to find on ultrasound and really have the ability to alter the trajectory of the patient by that.
And I liked how Amal said that initially, right? It's like, ask the nurse, what was the patient doing like right before they seized? Were they super short of breath, or were they fine and talking and said they needed to pee? Differentiating between possibly a pulmonary versus a cardiac cause, right? I mean, that could be like a one question sort of thing that could give you tons of information and can certainly lead you down a much different pathway. So let's move back to you, Amal, and then we're going to bring other folks in for this exact same question. This is a witnessed arrest, and not just a witness arrest, but a witness arrest in the ED. And most patients that I code went arrested in the field. They didn't arrest in front of us. So the ones that actually arrest in front of us, we would think that they have obviously an increased chance of salvage, right? As well, this guy is a 33-year-old, right? So this isn't, the 95-year-old, metastatic cancer patient. So, Amal, anything that you do differently when you're resuscitating, especially a young patient who has a witness arrest in the ED?
Sure. Well, I definitely agree with you that this patient's going to have a better chance of survival with an arrest right in front of a team of healthcare providers. People are going to move quickly, and you also probably have a little bit more information than your typical out-of-hospital cardiac arrest, where nobody knows what happened, and even the witnesses aren't there. But things can be very chaotic for the first couple of minutes in the emergency department. So I think as the emergency physician or team leader, you really need to get control of the room right away, because everybody's trying to help. Everybody is running into the room. You've got housekeeping staff running into the room. Everybody's getting in there and wants to help, but you've got to control the place and assign roles as quickly as possible. You need to make sure that somebody is on the chest doing good quality CPR as quickly as possible. You want to get the defibrillator on board, because if it is a shockable rhythm, you lose chance of survival with every passing minute. And then the most important pieces of equipment to me early on is suction. That's my to me, it's the most important piece of airway equipment that's so often forgotten. Get the suction working, and then just simple airway maneuvers up front, like chin lift, jaw thrust, can make a big difference. And I'm a big fan of nasal airways, and if somebody's out cold, get the oral airway in to assist with bagging, and then just blow by oxygen. Just like Scott was saying, I don't think there's necessarily a huge rush to intubate up front using an LMA, or if bagging is successful, I think that's fine. And then after that, trying to get some information about who knows the patient, what's been going on with the patient prior to the arrest, I think can really get the plan going.
All right, Brad, and then Jason. Brad, what are some bits of wisdom you can share with us for the witness arrest in the ED?
I agree with the other folks. As far as you want to set the team in the room up for success, you want to delegate and assign, have that closed loop communication. Remember, they say take your own pulse before you take anybody else's to keep calm. Good CPR, early POCUS, avoid CPR pauses. I think that, and if you can, just try to avoid getting to the head of the bed if you have a team there, so you can keep the whole picture in mind, not get locked in.
So I'm going to come back to something that Almost said earlier. Rubber meets the road. You are, again, this single coverage. You started this resuscitation. Maybe someone from the family says that the patient has either Danlos or whatever. Do you go ahead and order blood now? Or do you want to sort of wait and see how this initial part of the resuscitation goes? Brad Goldman.
Oh, I'm sorry. I thought you said Amal Mattu. if you have the resources, and remember, you can't do any worse than him not being alive, I would give it. I don't see any downside.
Okay. All right, Jason, give us some thoughts.
Yeah, I was thinking about the comments that Brad was making and earlier. Those arrests and those in-hospital arrests, it's a stress test of teamwork. That's what it is. It's a stress test of the department's efficiency and how well you've prepped for that event. It really is a real-life experience and a great opportunity to prepare and train and then execute in real time, and then debriefing afterwards. That's sort of what I was thinking about when Brad was speaking about the rubber hitting the road and going through that experience. But it's a stress test, and the preparation in advance, which really gives validity to practicing and going through it and communicating in real time and debriefing afterwards to talk about what went well and what didn't, so you can be better and better the next time. Stress test.
Okay, so here's what happens. The patient does have an ultrasound performed, as Scott had recommended, and showed a large amount of pericardial fluid. They did pericardiocentesis, only removed about 10 cc's of blood, but sometimes that can make a difference. Unfortunately, in this situation, patient's condition did not improve. Compressions are continued. They gave epi and calcium. So, Scott, I wanted to just ask some pro tips. What is your favorite view for doing the cardiac ultrasound during CPR? And what are some pro tips you use to minimize that time between compressions, like Brad was saying?
Yeah, if you want to do it during CPR, which is definitely possible, then it's going to be subxiphoid, and you actually could get views, I'd say, in about 50% of the people while compressions are ongoing. And at that point, just hold there for the next rhythm check, and your nurses should be pre-announcing. They should be saying 30 seconds to a rhythm check, and then you'll actually be able to see what the heart's doing without compressions, without having to spend any time on the chest trying to find the view, because you're already looking at it. So you'll just have an immediate ascertainment. You can figure out if they have pericardial fusion even during the compressions in many cases. And then after that, you don't really need to look anymore. So there really just should be an interruption of chest compressions, if at all, just for a second or two once. And then after that, you really should be looking at other structures that don't require chest compression interruptions. So looking at the carotids or the femoral for your pulse checks rather than using your fingers or looking at the heart saves you from ever having to interrupt compressions for that again. And then all the rest of the rush exam can be done without interrupting compressions. So it really, I see these people, they're looking at the heart every rhythm check. That's not the right way. That's what's going to cause poor on-chest fraction and potentially eliminate this patient's chances of coming back. So one time, just to ascertain, is there anything about the heart that gives you a cause for arrest? And then is the heart beating in the case of PA? And then after that, something really needs to change before you interrupt chest compressions again to get on the heart.
I want to emphasize something you said earlier, Scott, because when we changed in our ED to start doing this, for me, it felt like a huge, huge step forward, is that our nurses do run the code in the sense of like giving the epi and all that kind of stuff and the pulse checks and all those sort of things, right? And, to me as a physician, I need to remember every 5 minutes to be looking at the clock and have my concentration sort of distracted by remembering to give one of epi through all these different times. And Amal, like you've talked about too, those subsequent epis are not nearly as important maybe as those initial epis, if I'm paraphrasing you correctly.
Yeah.
But I just think that that is such an important process change that folks that are listening to this, who maybe are leaders in their department, can bring back to their own departments. Is let's have a nurse or even pharmacist run code, and then we can take the time to do the stuff that really might change the outcome with this patient. Scott, what do you think? They got 10 cc's of fluid off. Does that seem like an amount that could make a difference, or were they just in like a small pocket? Was there a clot like Sarah Stommer talked about a few months ago? Why do you think only 10 cc's came off?
Well, I mean, the real problem is, and they didn't specifically say they didn't, but oftentimes if I hear a paraxiphoid approach, they're not doing real-time ultrasound guidance, and they're just as likely to be in the RV as they are to be in the actual pericardial pocket. And it's why I think blind pericardiocentesis is really not the greatest way to go. And oftentimes that's the situation. Now, they said it's a large effusion, then 10 cc's might not be enough. When we see like an amazing difference from small amounts of fluid being removed, it's oftentimes when it's an acute tamponade type situation, in which even sometimes 2 or 3 cc's is enough. But if you have an enormous effusion, then 10 cc's might not have been enough if they were in the pocket. But my guess would be they were not even there.
Do you think, and of course we're all just guessing here, that one of the considerations could have been some sort of thoracic aortic dissection back into the heart and the pericardium that would have caused this effusion?
Yeah,
Would
I mean,
that change
that would
anything you're
put a
doing?
lot of this together. And on that first visit, it's interesting because the patient was hypotensive, which you really shouldn't see in a dissection without something that really does not allow the patient to sleep comfortably or to leave even, if you're massively exsanguinating to your chest, or you have an acute coronary syndrome from the dissection, or all the other sequelae that would cause hypotension, they don't really leave. But I think from that first visit, if you wanted to put it all together, if they were just taking a blood pressure on the side that wasn't being perfused as much, it was a spuriously low blood pressure. And especially if they just kept the blood pressure cuff on the same arm, then you'd see these fluctuating blood pressures, some low, some like mid-level, like we saw on the second repeat, when he might have had a profoundly hypertensive blood pressure on the other arm on that first visit. And then he could have come back with a ruptured dissection, rupturing back into the heart, and then potentially into the abdomen as well, when we find out later ultrasound. I believe he had free fluid in the abdomen. So yeah, it could be dissection, absolutely.
Okay, so let's do this now. Say that the code is continuing, and I'd be interested in just getting everyone's thoughts on this. And I'm going to actually put this up here while we're talking about it too. But might as well just stay with you, Scott. Then we'll do Amal, Jason, and Brad. But calling the code, this is, again, a young man he arrested in front of us. I think some of the data now is showing that, sometimes even when it seems super futile, sometimes you can get a person back. And I think, Scott, you had a recent MRAP episode where you talked about sometimes a little bit of a prolonged code. What are the things that you really hang your hat on showing a poor chance of survival, and some of the things that would tell you it's time to just call this code?
Yeah, well, and we also have inpatient data pointing to the fact that the longer codes are run, the better patients actually do. And that's, in terms of neurologically intact survival. So if I have a young patient like this, I'm going to run the code for quite a bit of time, probably upwards of 40 minutes before I'm going to start thinking that. And, it's different because it's witnessed as well. If this was a patient who had, extended downtime in the field, even if they're young, well, that downtime counts. And so I'm going to add on the time they're going to spend in the ED to that. And once they start getting around that 50-minute mark, it's pretty dismal unless ECMO is involved. And we could get into an entire discussion on that in another club. We don't have time for it here. But what ECMO turns out to do is just prolong how long you could survive with a downtime pretty amazingly, how far that could extend out. But without that, they're not going to make it past 50 minutes. So once they start getting to that point, then that's when I'd probably be calling it on a young patient. Now, intermittent ROS kind of changes the situation a little bit. That, gives a slightly prolonged time before you could just say there's no chance of neurologically intact survival. But this guy's 33. I'm going to run it an awful long time.
Okay. So just sort of, if each of us also could answer this, Amal, Jason, and Brad. And then I want to come back to Marc Calvert and a question asked by Robert Sweeney about shared decision-making with his AMA. So Amal, what are your thoughts on ending a code in this situation?
I'll probably just say ditto to what Scott said.
Okay.
I agree with, in a younger person, I'm probably going to run the code a little bit longer. If it was witnessed by us, I'd be more inclined to run it a little bit longer than compared to an out-of-hospital code in a 65-year-old. We don't know what happened. We could give some consideration to ECMO if it's an intractable, shockable rhythm. And then the other things to think about if you have an intractable, shockable rhythm is there's some literature suggesting throwing some beta blockers on board. There's some improving literature talking about dual sequential defibrillation. It doesn't sound like that was the case here. And also, if you have a reversible cause, then you're going to pursue it a little bit more. So you guys brought up the issue of a pericardial tamponade as a possibility. 10 cc's, that's not a lot. And with a large effusion, I might be inclined to try to pull off more just as a possible reversible cause. But I'm not really sure I have much more to add than just keeping your fingers crossed and hoping that you get lucky.
Okay. All right, Jason, ending codes.
So you want me to add something after Scott went and then Amal went and pick up what's left over? Sure. It's a lot. This is a young person that died in front of you. And I think it's sometimes harder to separate. We could look at CPR greater than 20 minutes. We could look at end tidal parameters. We could look at a lot of different recommendations and professional associations with clear guidance, but these are hard to walk away from. That's what I would say. And I think you do everything that you can for as long as you can until everyone is comfortable. And especially if there's a family member in the area who could potentially come in and some other variables that may come into play. I think that Scott and Amal articulated everything. I don't have much more to add. I just
Okay.
wanted to acknowledge you have a young, healthy person there.
Right. Got it. So Brad,
I keep saying healthy, relatively healthy.
No, right. I get it. So Brad, I'm not going to put you on the spot for this, but we'll give you a couple extra seconds for a closing thought. So what I want to do here is first tell you what happened with this patient. And the code was called, they did 26 minutes, so not Scott's 40 minutes, but at least that's what the provider did. They did 26 minutes of ALS, and they had unsuccessful resuscitation, and a autopsy the next day showed the patient actually had mesenteric ischemia. So interesting cause of death in a 33-year-old, but maybe thinking about some of the vascular issues as well as the cocaine use, it would sort of come together. Scott was saying, like, well, it doesn't really make sense that they dissected, but it was 7 hours earlier that they were also dissecting with that hypotension. And so maybe this puts all this together a little bit better. I wanted to just, before I ask each of all of us for our closing thoughts, and we'll have about maybe 45 or 60 seconds per person for that. But Robert Sweeney asked a question about shared decision making. I think this was a reference to AMA. I'm going to actually just sort of answer this myself, a little bit of a pet peeve, a little bit of a rant, but I'll do it quickly, is that to me, shared decision making is the decision between two reasonable alternative pathways, but it has to be done with the guidance of us, of the physician. And we have to do that and not abdicate our responsibility. And what I see so frequently happening with shared decision making is us using that as a CYA. So instead of SDM, it's CYA, that we can sort of put some of that back on the patient in case there's a bad outcome. I'm not sure if it's legally protective, but I do know that I don't think it's fair to the patient to do that. So if we're doing shared decision making, it has to be between those reasonable alternative pathways, but also with our guidance to the patient. So let's do this. Let's have each of us, and Marc, I'm going to have you go last. But Brad, because we sort of skipped you on that last time, if each of us want to give about 60 seconds, maybe 45 seconds of the main thing you'd like all of us, as well as the participants, to take away, and then we'll flash that QR code back on so people can get their CME. Brad Goldman, why don't you start? Jason, you'll be next. We'll do Amal, Scott, and then Marc, you can bring us home with the legal issues on this. Brad.
So my quick thoughts are for AMAs, especially for the younger trainees and people just out, is don't take it personally. I've seen this often. It gets you into a bad mindset. Try to be the creative/crafty ally. As far as the scans, I don't even wait for labs. I don't know what that oral contrast was about. Go full bore, just get it with IV contrast if you need it. Again, contrast-induced nephropathy, I believe, is a unicorn that's looking for a place to stay. And then as far as with the documentation, just make sure you tell the whole story. It doesn't have to be very wordy, but just to get the salient points across, that you try to do the best that you can and just document what it is you said and who you said it to.
All right, nice. Jason.
Patients come and go, but the medical record lives forever. So I think in the first visit, there was a real opportunity, and to Amal's point that he made at that time, is that no reasonable and prudent physician would knowingly discharge that patient in that condition at that time. And I think we would all agree on that, but the patient felt compelled that they had to leave for whatever reason. So documenting what transpired during that conversation prior to the patient leaving could, and it was done very well. There are opportunities for it to be a little bit better, specifically relating to the teach back moment of what I'm concerned about and what you can communicate that back to me, the risks, benefits, and alternatives. And then if the patient absolutely has to leave, doing the best that you can with what you've got. So if it's a patient with an infection, just making sure you give them antibiotics and making it clear that if you get any worse or you're not significantly better very soon, just come back. Documenting that offers some degree of protection later.
Amal?
Yeah, I guess I'll reiterate something that Marc said earlier, that when you document, you document as if your chart's going to be read in court. And that's certainly the mindset you need to have with these high risk type of patients, and especially for those of us that are in litigious areas. What I'll tell the residents sometimes with these high risk patients is, if you're thinking about sending this patient home, imagine that this patient is going to be dead tomorrow. Is somebody going to look back at my chart and say, you know what, I probably, based on what you documented, I would have sent that patient home also? Or are they going to say, what the heck were you thinking? And that's the way you've got to document your chart in high risk patients. I'm not saying every ankle sprain and this and that, but with high risk, you've really got to have a certain level of paranoia to demonstrate that you did what's reasonable.
I love that point, especially when that initial provider knew something bad was going to happen. Yeah, thinking, how would you want this read, not only in court, but to the family or to the department chair, right? Scott.
Yeah, I mean, just to go on with what Amal was saying, I ask on every patient, whether they, are seem serious or not, is how am I going to get M and M'd on this patient? And that pre-mortem cognitive exercise. And oftentimes I'll say, I can't see a way. And then that's a safe discharge. But if there's any way, then you either have to reevaluate your plan or you have to document as to why it was understood that this could be a problem, but you still went through with that. And then on the AMA, the last thing I'll add is I like to express some emotion too. So I will actually write on my AMAs on a patient like this. I pleaded with the patient to stay. I understood how serious this was and begged the patient not to go and told them I will do anything it takes to take care of the things that are forcing them to leave. I really want it to be understood when they look at that chart. I gave a crap, because if that doesn't come through, then that's going to be a really a big strike against you.
Marc Calvert, bring it home for all of us.
I don't know that I can improve on what's been said. It's been excellent. I would say the two pillars in this situation would be terrific bedside manner, great patience, taking time, sitting down with them, going over it, maybe drawing it on a dry erase board or on a piece of paper, really giving your best closing argument, and then having a great note, which is supplemented by a witness who was there and saw that. I think that's the two nuclear bombs that will help you out.
Marc, knowing what we know about the diagnosis and the outcome, obviously death 7 hours later, do you think that this initial chart, if it would have gone to legal action, was that initial chart defensible?
It was defensible, but it makes it a closer call. I think with really just a little bit more time and passion, as was just mentioned, it becomes more dispositive. When I look at it, it's a little bit light, it's a little bit skimpy. We can work with it, and I've certainly seen worse. But why not take an extra 10 seconds and make it kind of an A+ note instead of a B-?
I know that we're 1 minute over, but last thing here, Marc, I've seen people say, well, AMA note or medical decision making note. And if I was given that choice, of course, I'd go with the MDM, not the AMA form. But if you're having so many AMAs that it's taking a lot of time out of your practice, to me, it feels like you just do both, especially in this situation when this patient is so morbidly ill.
When the patients are high risk or extremely difficult, I think you have to pause and realize this is the landmine filled field that really poses risk to me. I've got to be careful with this family. I've got to be careful with this patient. So the double forms is fine. A better note is ideal.
Well, thank you so much, not only to our panelists, but also thank you to folks who have spent an hour with us tonight, taking an hour out of your Monday night. We are not going to have a book club next month because I will be shuttling between the ACOEP and the UCA conferences in Arizona and Las Vegas. But we will resume on May 1st, and here's the QR code to register. You can always go to the website to register, as well as see all of the past book clubs, except for the 2 where there were technical difficulties. So just EM like emergency medicine, embouncebacks.com. Here is the QR code for the free 1-hour CME credit. Thank you so much, everyone, again, and have a great night. We will see you all May 1st.